Well, thank you so much for having me today. It's really a pleasure to be here to talk to you about exploring innovative solutions and models of success in genomic studies. I am a nurse scientist. I think I'm the only nurse scientist on the panels today, and a pediatric nurse practitioner, so I do have clinical relevance as well. I'm the Vernice Ferguson Professor in Health Equity, so all of the research that I do centers around health equity and genomics. So I was invited here today to talk to you about genomic studies and minority populations and to provide some recommendations on what we can do to increase diversity in genomics. So I want to just, as a background, talk about some of the studies that I've had the pleasure of leading over my last 24 years of funded research. So starting off early in my career, I was funded to conduct a three-generation study in Detroit with 3 generations of African-American women, where we examined gene-environment interactions on blood pressure. Now, I know throughout the day we've talked a lot about cancer, whereas my work has focused on common chronic diseases such as hypertension. So in this study, we were very interested in the interaction of lifestyle factors like diet and physical activity and genomics on blood pressure. And we had significant findings with sodium and genetic factors that significantly increased blood pressure in this population. And then I was able to obtain funding to replicate this study in Mali, West Africa, with 3 generations of Dogon women naturally controlling for diet and physical activity. Because in this population, these women still live the same way they've lived since the early 1400s. They still hunt and gather for food, and they're mostly underweight instead of overweight in the Detroit population. And we found the exact same significant findings for genetic factors that were related to increases in blood pressure in this population. And it was important to look at the Dogon population because they were a large part of the transatlantic slave trade to the Americas. Then moving on to replicating the work in larger epidemiological samples of African Americans, I was able to replicate these studies in the Genetic Epidemiological Network of Atherosclerosis and the Hypergen study, both part of the Family Blood Pressure Program. And we had significant findings as well. And currently, I currently work on an R01 funded by the National Institute for Nursing Research, where we are collecting data on African-American women and their young children, looking at the impact of genetic and psychological factors on blood pressure in mother-child dyads. And we are recruiting from Head Start programs across Connecticut, and we are looking at psychological factors such as perceived racism and discrimination, symptoms of depression, and parenting stress among these mothers. And I think what's interesting and innovative about this study is that it gets at the issue of race, but also it extends the notion of race to what society makes you feel. And that's really looking at racism and discrimination and how that can affect your health. And then lastly, I'm also working with a group of investigators in Michigan. I'm originally from Michigan, so when the Flint lead crisis happened, water crisis happened, I was, more than affected by this. So I'm working with investigators in Flint on looking at genetic and environmental multi-generational study, looking at families in Flint, Michigan, looking at their genetic risks, and also the environmental factors that increase their risk for common and chronic diseases. So some of the environmental factors that we're focusing on in Flint include also perceived racism and discrimination, but we also look at trauma, because this is an extremely traumatic event that happened to them, and resiliency and coping, and how these individuals and families are coping with this crisis and still living now more than 3 years later, still with no clean water in Flint. So I also wanted to offer some of my experiences on community collaborations and what I feel were the keys to the success of the studies that I've been able to lead and be a part of the key leadership. While I was faculty at the University of Michigan, I was able to access participant resource pools, and these were offered through the Women's Health Registry at the University of Michigan. And though that registry was extremely helpful for the 3-generation study that I did in Detroit. Also, there was a participant resource pool at Wayne State University, which is located in Detroit, about 40 miles from Ann Arbor. And that registry was located within their Institute of Gerontology. So I was able to access information on the older generation that would participate in my 3-generation study, the grandmothers in the 3-generation study, and that was extremely helpful because once I contacted the grandmothers, all the other 2 generations pretty much came into line and participated in the study. Another great resource was working with a historically Black sorority, Alpha Kappa Alpha Sorority Incorporated. Now, this was something that after I actually started recruiting for the study, I am a member of this particular sorority, and we have monthly meetings. I attended a meeting, and it dawned on me that this was a great potential resource because there are multiple generations of Black women that are a part of these historically Black sororities. And there are more than 200,000 members of Alpha Kappa Alpha Sorority Incorporated worldwide. And this is just one of many historically Black sororities. I also work with, after working with Alpha Kappa Alpha, it really dawned on me that I should really try to work with the areas of the community that I participate in. So Jack and Jill of America is another community resource that is a group of families, Black families throughout the United States. There are more than 40,000 families that are members of Jack and Jill of America. And currently with our current R01, we are recruiting from Head Start programs across Connecticut. We recruit from the YMCA, which also has a Head Start program. And we're very engaged with community outreach, community things that happen in the community. We participate, our entire research team will take part in health fairs, do blood pressure checks, just to make our presence known and get to know people in the community and let people know that we are there and we're there to stay. It's not just a one-time thing. We're developing relationships. I've also, and it's a reciprocal relationship as well. Even though we're a research study, I invite people from the NAACP. I ran a summer intensive at Yale University last summer where I was working with junior scholars in health equity research, and I wanted the local chapter president to come and talk to these scholars to talk about what are the activities that the local NAACP, what are they active in, and what would be useful for the community when it comes to people that want to do research in the community. What can we do as researchers to help the community? We don't want to just take. It's a give relationship as well. So it was wonderful. We had the president from the New Haven chapter, Ms. Rory Dumas. She came and gave a talk to our scholars, and it was a wonderful exchange. And what are some of the ways that we can get healthcare to all people, and how can we solve the inequities to access? Well, coming from a person that does community-based research, I think that we really have to get away from waiting for people to come to the clinic. We have to go where people are, go to the community, reach out to the community, find out what it is that they want and what they feel like that they need, and actually provide those services in a community-based manner. In Detroit, I was fortunate enough to run a mobile health clinic, and we provided services to school-age children, mostly on the east side and southwest sides of Detroit, which served mostly African-American and Hispanic families. And it was one of the most fulfilling and wonderful things that I did as a clinician. So waiting for people to come to the clinic to get a DNA test or to get screening for a genomic risk factor, I think that is not the way. If you've ever gone to an academic health center, you know that it can be a barrier just to find where you're going, to find parking, to find the clinic, to actually find out where you're going, to go to the next place. Where do you go to get your blood drawn? Where do you go to see your physician? Who do you go to next? When do you get your results? How do you access those results? It is more than a notion to go to an academic health center and actually navigate through that process. So I feel like going to the people is better, could be a better method. Also, utilizing mobile health and research vans and telehealth. I know we've talked about this several times today, so I won't reiterate this, but I think that when people see you in the community and you have established these relationships with people in the community, then they are more than open to participate not only in research, but also to come to you for what they feel like is something that they're interested in terms of being screened for their health. Also, as a researcher, I think it's imperative to participate in things that are going on in the community. If there are community forums around a specific topic, around something that's very important to that community, you may want to see how you can be a part of that and how, as a health provider, how can we be useful? Maybe talking with some of the leaders or organizers of different community events and seeing how your unique set of skills can be useful, can also lead to opening doors to various community organizations. Because we recruit from Head Start programs, we also participate in parent meetings. We will go to schools either early in the morning or in the evening or during drop-off and pickup time for the children. And we set up a table with all of our materials. We talk to the parents as they're coming in or leaving out with their children. We ask the parents, what are some of the concerns they have for health for their children? Do they have certain health concerns for themselves? What do they think about genetic testing? Would this be something that they think will be helpful to them and for the future of their children? So we actually go and we talk to the parents to see what it is that we can do to be of service to this community. And also, when we have our results available from our studies, we don't just present them at professional organizations like we present here or at American Heart Association or International Society of Nurses in Genetics. We present at these parent meetings. We provide newsletters to the parents, to these community organizations. We say, look, we're targeting to recruit 250 families. We're now at we have collected data on 200. We only need 50 more. How can you help us out? What can we do to meet this target? We outline some of our results, what the average blood pressure readings are in this area, what have our genomic findings been thus far, and where we're planning to go in the future. So it really keeps the community engaged with what you're doing, how far you've gone in your research, and what you plan to do in the future, and how that will affect them not only right now, but also in the generations to come. So the sororities and fraternities, they have conferences annually. There's also an annual conference of Jack and Jill of America, which I'll be attending this July. So presenting at various organizations that are not necessarily academic conferences. And also, I think the bottom line of this is just being present. Being present, letting people know that you care about them and their well-being, not necessarily just trying to hurry up and get your data so that you can write a report. You need to let the community know that you are truly, that you truly care about them, that this is not only for right now, this is for their future health. And, if this is something that you would do yourself, you could let them know, things about yourself. So I share a lot about myself with my community partners and with the families. I talk a lot about, yes, I've had my DNA tested, I've tested my children, and I think this is something that can be useful for you as well. So how do we overcome these barriers? One, I think being a community advocate, I think that we should expand genomic screening programs to community venues and to community organizations. If we're going to be involved with these organizations, what can we provide? We do breast cancer screening, we do blood pressure screenings. Can we do genomic screening programs in the community as well? I'm going to go out on a limb and say something provocative here. We should include more underrepresented minorities as PIs and key personnel in these genomic studies, because we are highly underrepresented when it comes to genomic studies, but we are asked consistently to serve as consultants. But that does not provide the leadership that is needed, I think, to really be effective in recruiting in minority populations. And also, it does not provide not only the leadership, but then who is responsible if something goes wrong. So you need to have someone or a group of people that can be responsible and who are connected to this community to actually, show that you care, make sure that things are done the right way, and to guide the other investigators that have not had the opportunity to work with these populations in the past. And then lastly, increasing genomic training programs, not only in graduate and undergraduate programs, but also K through 12, and then including genomic training for current clinicians and researchers via license renewals, continuing education units, and the like. Thank you so much for your time and attention. I'm happy to take questions with the panel.